So good morning, everyone. And hi, welcome to WeRPN Nursing Week 2021. My name is Norma Tomlin, and I'm pleased to be your WeRPN host for today's event, focusing on palliative and end-of-life care. Every year, Nursing Week gives us a chance to come together and celebrate our amazing profession. This year has been particularly difficult, one for so many of you. On behalf of Ontarians everywhere, we want to take this opportunity to express our deepest gratitude to you for everything that you are doing and everything you are doing throughout this year. This year, we are hosting a series of virtual events that are open to all nurses. Each of the days will focus on a theme that is central to promoting elements of self-care and wellness. Today, our Education Day, and our theme is Reinvent. To kick off the day, we will have a short video we want to share from the RPN community.
What have I learned this year? I feel like everything was just learned this year.
One thing I've learned about myself over the past year is that I can accomplish anything that I set my mind to, so long as I put the work in.
So for me, learning to say no and learning to be like, as much as I want to be of help, I don't think I am mentally there.
This has forced me to step out of my routines, and it's been healthy, I gotta tell you.
I'm probably pretty stronger than I thought.
I think just realizing for me that I'm definitely in the right profession and just being so proud of being a nurse.
So we'd like to send a special thank you to all the nurses who share their voices with us. Now, I'm pleased to introduce the main event for today's session. Our speakers today, Leslie Hertz from the Ontario Palliative Care Network. Leslie originated from the UK, where she completed her registered general nurse and clinical specialist training. With over 31 years in healthcare, she has extensive clinical leadership experience. She was the inaugural president of the Palliative Care Nurse Interest Group of Ontario and the Palliative Care Outreach Consult at the College of Nurses of Ontario. As she has also held roles as the Director of Cancer Care Services, Executive Director for Hospice, and Chief of Nursing Practice at an academic teaching hospital. Leslie's current role is the Director, Regional Practice Care Network, and IPAC Lead for Ontario Health West. A believer in lifelong learning, mentoring, and coaching, Leslie is a professor at Mohawk College. She has made a commitment to be an ally of Indigenous peoples and strives to continually improve and create a system which is safe and meets the needs of all peoples. Leslie holds 2 master's degrees, Master's of Science in Palliative Care and Oncology, and a Master's of Nursing Nurse Practitioner. Next, we have Jackie Davis. Jackie is a palliative care nurse and a WeRPN board member. As a pediatric palliative care nurse at the Roger Nielsen House in Ottawa for the past 10 years, Jackie says she is fortunate to have engaged in several forward-thinking initiatives. Jackie has worked in several healthcare environments such as adult medical, surgical, convalescent care, home care, and most recently, like many nurses, COVID-19 assessment and vaccine clinics. For the past 2 years, Jackie has the privilege of representing nurses on the WeRPN Board of Directors as a director for Region 5. Next, we have Carolyn Tangitio. I'm sure I didn't say your last name right, Carolyn. My apologies. Carolyn is a registered nurse and advanced practice consultant with the College of Nurses of Ontario. She has a decade of nursing experience, ranging from critical care work in various intensive care units across the GTA, and experience in adult education, teaching the RPN nursing program and internationally educated nursing program at George Brown College. She's received a Bachelor's in Science of Nursing degree from Ryerson University, a Master's of Education from Athabasca University, and currently is pursuing a Doctorate of Education from Western University. It's now my pleasure to turn it over to Leslie from the Ontario Palliative Care Network to kick off this morning's session.
Thank you, Norma. I appreciate that. And thank you so much for inviting me. It's a real pleasure to represent the OPCN today and bring with me knowledge that can really help all of us in our nursing careers. And it's just lovely to be part of this. So thank you. Norma, I'll just look for you for a head nod that the presentation is on the screen. So that's super. So I'm here today representing the Ontario Palliative Care Network, and a couple of years ago we launched a competency framework for palliative care. And as you heard there in the introduction, my career was born and started in the UK, and I came to Canada 17 years ago and was surprised that we didn't have a competency framework to really outline the standard of care for palliative care. So this is a really tremendous milestone, not just for the Palliative Care Network, but for the palliative care community as a whole. So as I slide through here, excuse me. So our objectives today really is to define palliative care, provide an overview for the competency framework, and then we'll just highlight some of the specific competencies that are outlined to nurses. The competency framework actually represents more than just nursing, but we do appreciate that nursing is the profession that really touches the patient the most in the core team day-to-day activities. So palliative care is an approach to care that supports individuals from diagnosis with a progressive life-limiting illness. It does include end-of-life care, but it is not limited to end-of-life care or the time immediately preceding death. And this is one of the myths that we really try and overcome. Most people think it's the last few weeks of life, but really it's from diagnosis, death, and beyond to bereavement. The approach helps patients and their family members prepare for and manage the disease trajectory, the process of dying, end-of-life planning, and actually coping with loss and grief. And the aim is to improve the quality of and manage the patient's physical, psychological, cultural, social, spiritual, and practice needs. So not just focusing on the disease itself and the physical constraints that may bring. And it's most effective delivered by an interprofessional team, which is person and family centered, person and family directed. It respects people's social, spiritual, and cultural practices. And again, that team includes volunteers, it includes the community. And the key piece is it's not a labeled patient type. So we really try not to refer to palliative patients, but patients receiving a palliative approach to care. And the intent is that it doesn't hasten or it prolong death. It really is focusing on improving quality. So what was the rationale for having core competencies? Well, competencies, as you know, refer to the range of knowledge, attributes, skills, and behaviors that enable you to effectively perform a certain role within an organization. And competencies are important because they can inform academic curricula, professional development programs. They can help prepare providers to apply principles of palliative care in practice. But the outcomes for the patient and families are that they enhance the care that people with these life-limiting progressive conditions receive. And they also foster greater interprofessional and inter-organization collaboration. So when we think about transitions in care and all of the care teams and care settings that somebody who's receiving a palliative approach to care may be in, these interprofessional and interorganizational enhancements really result in patient outcomes. So why did Ontario need this? Well, as I mentioned earlier, there wasn't anything that really guided the standard of care. And so when we think about this for patients and families and caregivers, it provides an expectation that the providers have the appropriate knowledge and skills to deliver high quality palliative care. For healthcare providers, it can identify gaps in education and training. It can also help with orientation and onboarding, hiring practices, and it really outlines the different types of competencies that you need within the team to be able to provide that comprehensive holistic care. And for the system, it actually strengthens service capacity and human capital because it creates this consistent and standardized education and competency requirement. So if you think about the latest issue with COVID that we've had in ICU and critical care, there's quite a clear standard there for a critical care nurse, and we're creating the same here for palliative care. And there's a continued need to provide advanced education for those working in palliative care as population ages, as disease and life-limiting illnesses increase, and we see this in our demographic. We know that there is a need for palliative care across the system. So the competencies are really divided into two levels. Level 1 are shared discipline-specific competencies for all health professionals and volunteers who care with people in life-limiting illnesses and their families. And when you think about this, we often refer to this as the generalist level. So regardless of where you are and regardless of what your team is, there's a generalist basic competency level that people should have in order to deliver high quality palliative care. Level 2 are shared and discipline specific competencies for professionals and volunteers that have a practice focused in palliative care. So while I can see Jackie on my screen and knowing that she works in pediatric palliative care, there'd be a higher expectation for Jackie working in pediatric palliative care because this is her day-to-day work. The framework actually covers multiple professions. So you can see here that we've got pharmacists, we've got occupational therapists, medical radiation and imaging technologies, we've got paramedics, speech language pathologists. So we've really looked at this from a very holistic view, and that also includes the volunteers. So the competencies are organized into domains, and these are the following domains. And so you can see they align very much to palliative care in specific areas such as loss, grief and bereavement, optimizing comfort and quality of life, care planning, collaborative practice, last days and hours. But you'll see as well that there are a number that actually overlap with other areas. So these competency domains can really help you if you're working outside of palliative care. So think about care of the elderly, think about on your general medicine units, you know, cultural safety and humility. So you can really start to identify key performance indicators, key competencies for yourself that you want to grow or you want to maximize, as well as you might have indicators here that you are really skilled at and you want to showcase those to your team. When we think about Indigenous allyship and our First Nations, Inuit, Métis and urban Indigenous competencies, there's a separate specific list of competencies that people should have for that. And it's really important to be aware of your own biases, your own needs, how much education you've done. And so the development for the competency framework for palliative care really involved a separate review and validation process. And that was driven by our First Nations, Inuit, Métis and urban Indigenous stakeholders. And this is because some of the Western recommendation competencies would not necessarily be applicable to caring for our Indigenous peoples that have a life-limiting progressive illness. And there are some new competencies too that are important for providers to develop. And that again can meet the cultural and safety needs of our this particular group. So a framework is only as good as the ability to apply it in practice. And when you think about the varying practices that we find ourselves in, the framework will allow you really to sort of put that into context and have that common understanding of the skills that you need for palliative care delivery. And then if you're in a particular setting and you think, well, I can't quite apply this, it can also inform you to think about, what education do I need? Where's my learning plan to help me improve upon this? It can also help with quality improvement too. So when you look at, if you're in long-term care, one of the quips there in long-term care is that people have adequate pain relief. So it may enable you as well to do some quality improvement there. As we've mentioned already, it can inform academic curricula and professional development programs. And it's also supported the implementation of other documents that we've developed, such as the Health Service Delivery Framework for adults receiving care in community settings. And this is a little bit of a roadmap of how the team comes together and really delivers high quality palliative approach to care. And this is all supported through the implementation of the Palliative Care Quality Standard, which was developed what was then Health Quality Ontario and is now the Quality Branch of Ontario Health. So there's lots of resources really for you. So here's the really exciting piece for nurses, and this is palliative care competencies in all practice settings. So when you go to the document, if you were to read the competencies, you'll see that there are intersections. So one example would be recognizing the potential for conflict in palliative care decision-making and contributes to its management. And that would fall under communication. And then if you look at the intersection, so where there's some overlap and some relational connection in the competencies, recognizes personal biases and values that may influence care and identifies mechanisms to overcome these and ensure that they do not impact on care and treatment. And that's in cultural safety and humility. So again, without recognizing the personal biases, you wouldn't be able to recognize the potential for conflict in palliative care. So this is where there's a lot of intersections within the competencies. And then taken together, there's this big thematic overview. So nurses in all practice settings reflect a philosophy of palliative care. Again, it's a philosophical approach to care that improves to aim quality of living and dying. It enacts a knowledge-based and relational practice, and it allows you to play an active role in the care process. So when we think about the knowledge and application, the common trajectories of life-limiting conditions, including common symptoms, this would be knowledge of those. And then when you think about application, you would be able to understand somebody's diagnosis. So let's say somebody has lung cancer and their prognosis is around a year. You know from the knowledge that you've gained the trajectory that that person may experience. They may be well for some time, and then there may be more of a decline towards the last few months and few weeks of life. And so you can anticipate that. And by anticipating that and applying that knowledge, you can enable the person to develop their care plan with you through their expression of wishes, as well as their goals of care. So preferred place of death, for example, it could be care planning. It could be outlining the most important symptoms to them. Maybe it's pain control, or maybe it's the ability to mobilize so they can remain ambulatory and independent for a period of time. So this is where that knowledge and application really works well together. So in terms of classification, when you think of classification of nurses, we tend to think RPN, RN, nurse practitioner, but in the competencies, we think of generalist or specialist palliative care. So an example of an RPN specialist, an RPN generalist could be an RPN that's worked in the community for 10 years. They see a variety of different patients. Sometimes they care for a person receiving palliative care, but it's not often. They may have completed the fundamentals of palliative care certificate, and they're able to meet many of the palliative care competencies for nurses in all settings, but they're easily able to identify that they've got some learning needs, or they need some support from somebody in a specialist role if they have a person with complex palliative needs. Examples of a specialist level RPN would be an RPN that's worked at the hospice for 10 years, for example. They've completed a number of different courses, a college certificate in palliative care, the fundamentals of palliative care, and the certification for advanced palliative care. They mentor and orientate new staff to palliative care and also help them with their learning needs. And they're able to demonstrate the additional competencies for nurses specializing in palliative care as outlined in the competency framework. So you can see the two differences there just in the RPN role. So I think when you reflect on the document, you'll easily understand where you should be in a generalist or specialist role. And the easiest way is, day to day, do I generally care for patients receiving a palliative approach to care? And if the answer is yes, then your expectation is that you're functioning at that specialist level. So as we sort of wrap up this presentation, really what I'm leaving you with today are some discussion and reflection questions, and thinking about what strengths and what challenges specific to your context exist in developing palliative care competencies. These can be all kinds of challenges, or maybe it's access to palliative care mentorship. Maybe it's because it's access to palliative care education, or maybe you're already in a specialist role and you want to take your role to the next level, and you're struggling to do that. Maybe it's COVID. So when you look at the document and you start to outline, where do I really need to enhance my practice? What skills could I transform to deliver a higher quality palliative approach to care? It's a really good tool for you to do that. And then how do you see yourself? How do you see your role? RPNs are such valued members of the team, significant in terms of their practice and their practical approach to care, and often in particular settings are the primary discipline that's with the patient day in, day out. So, for us, in terms of that holistic interprofessional approach, we see the RPN role has real value, leaders in their role, particularly in a specialist role. But how do you see your role? And when you look at the document, what resources could you access to mitigate any competency gaps? So this ties into, we're all familiar with doing our learning plans, but how can you build in some learning plans specific to palliative care? How do you reach out to that? As mentioned earlier, I'm in the Regional Palliative Care Network. Every area has a regional palliative care network. There's resources there. There's lots of resources, but how would you access them? And so I want to thank you again for inviting me. And just before I sign off back to Norma, just to highlight, as you receive this presentation that we did for you today, there's a number of resources towards the end, specifically more to aligning the framework, special considerations. We do want to acknowledge WeRPN was such a great stakeholder in validating the competency framework for us. Obviously, we've got our colleagues here from the College of Nurses, which I'm also very familiar with, and that's also in the context of ensuring that we practice within our regulatory standards. We've got the members there, the colleges that also provided endorsement, and the link is right there at the beginning of that document. So thank you very much. You are more than welcome as well to reach out to me following this presentation if you do wish to know more about palliative care, but I do hope it's inspired you to take a look at this document, outline where your practice lies, and start to develop a learning plan to enhance your palliative skills. Thank you. Back to you, Norma.
Thank you so much, Leslie. That was fantastic. And I'm just going to let everybody know we do have the Q&A function at the bottom of your screen, and we will have a Q&A opportunity at the end of the presentations with all the speakers, so that you can certainly put your questions in there. We'll be collecting them to have a further discussion as we move forward in the presentation. Now I'd like to actually hear from Jackie. And Jackie is the palliative care nurse in her practice. This is her role at Roger Neilson House. And she's also a WeRPN board member. And so we're going to talk a little bit about her experiences. And Jackie, so we're going to do a bit of a back and forth conversation of how have you incorporated palliative care competency in your work day to day?
Okay, so the work I do at Roger Neilson House, which is an 8-bed pediatric hospice here in Ottawa, focuses on holistic, multidisciplinary approach to care. Our goal is to provide supportive comfort care. We have to incorporate expertise. We have to have the expertise in assessing and understanding complex symptom management as we support our children from the time of their diagnosis right through and to end of life care. Aside from the clinical expertise that, of course, RPNs have at Roger Neilson House, communication is a huge factor in the care we provide. And there has to be comfort level with navigating difficult conversations as well.
Absolutely. And as a nurse that specializes in pediatric care, can you talk about your practice that involves the family? As we know, it's an integral part of the care that you provide.
A family-centered approach is extremely important in the work we do. Ideally, the children and their families receive the support of a palliative care team at the onset of diagnosis. At this point, we introduce a series of supports and services for the entire family, the child and their family, to address their physical, their emotional, their spiritual needs. And when I say family, I mean, this includes the parents, the siblings, maybe grandparents, or anybody they identify as a family member. Discussion regarding the goals of care is an ongoing event. We try to stay open and curious when developing the care plans with the input of the families. The families are the experts when they come to their children, and we ask them to lean into this knowledge and share it with us. As a matter of fact, Roger Neilson House is the first pediatric hospice in Canada to use electronic health records. And we intentionally designed our workflow that it allows the parents to provide input on their child's care that can be incorporated into the care plan of the child. We're pretty proud.
That is fantastic.
Yeah,
that is really fantastic. And I love the fact that you mentioned the siblings as well, and that inclusion of family in the conversation. It's so very important. How do you strive to incorporate the voice of the child in the care and decision making, including seeking agreement if they're not capable of providing consent?
Okay, yes. So a lot of the children we have and we work with do have cognitive impairments, which do affect secondary to their underlying conditions. And of course, this will affect their ability to participate in decision making. Again, we look to the family and their expertise with regards to their child and the needs of their child. We encourage the families to notice nonverbal cues, and we too look for those nonverbal cues. And the wonderful thing about, because we have so much time we spend with these families and these children, because some of our children are part of our Roger Neilson House family for years. So we do learn how to pick up on those cues. So we encourage the families to pay attention to those as well. And I'm just thinking, it's so important to support the families in their decisions, because, if your child can't speak for themselves, the parents want to ultimately do what is best for their child. One example I would think is like if a child's approaching end of life care, a lot of and if there seems to be like an increased level of congestion and discomfort, you know, having a discussion with the parents that maybe this is an indication that their needs are changing, and we can, this is one of the ways that their child is able to communicate in a nonverbal manner, that we probably need to slow down or decrease speeds.
Yeah, it's a matter of kind of redirecting and supporting all at the same time, as much as possible. And as a nurse in palliative care for as many years as you've been in palliative care, how do you remain resilient?
It's work. It's work. I will say I'm not. The years have helped because it is so easy to not take care of yourself. You know, we encourage the families to take care of themselves. We you know, but we kind of put ourselves back and just think we can handle everything, you know, but you can't. It will get to you eventually. And I have over the years developed a couple of strategies that I know are very important for me. First thing I would say is make sure you have someone you can talk to, whether that's a coworker or a friend, someone you can text and say, hey, do you have a minute time to talk? Second thing is I live an hour from my work. So that drive to and from work is my decompression time. The radio's off and it is so important. And I run a lot. So I get out of my own head, and, you know, it gives you that chance to get rid of the anxiety and the frustrations that you may feel. And it's even like, I know running's not for everybody, but if you can just get out with the sunshine on your face, it is helpful. And of course, sleep. I'm really, really good at sleeping. And they help. All those things help. And if I don't, and I do, if I skip one of those, it makes a difference. And I'm very fortunate to have people in my life to say, are you okay? And so it's great to have those supportive people around you.
Yeah, absolutely. With so many of your nursing colleagues that don't work in palliative care being faced with you know, the COVID-19 pandemic and the amount of death that has occurred, what are some of the things that you would recommend to those nurses that are finding themselves in that position to cope? And I know you've mentioned exercise but is there any other additional strategies that you could offer to your colleagues who are finding themselves now in these positions?
The most important thing I would say to anybody who's finding themselves in a situation where they just seem overwhelmed is reach out. Reach out to somebody. Don't try and manage it by yourself, because it's not good for you. It's not good for anybody. Just don't be afraid to reach out and say, hey guys, I need help. I need, whether that's just time off or just someone to listen. You don't need someone to fix everything. You just need a voice there to hear you and just reach out and to somebody that you trust, that you think can just be there for you. And it's such an important thing. And don't be afraid to say no. Do not be afraid to say no. Like I know we all do it. We don't want to disappoint, and we don't want to seem like we're letting people down, but you're no good to anybody if you're not healthy. And just remember that, you know, it goes right back to the whole airplane. Put your oxygen mask on first, because you're no good to anybody if you're not able to do your job.
No, absolutely. That's amazing advice. And, you know, certainly with your expertise and your knowledge that you're providing, that insight and understanding, and really your perspective is so appreciated during these times, Jackie. Thank you so much. And, you know, keep doing the great work that you're doing. We thank you every day, all of the RPNs that are out there, and you're doing some wonderful work to support families at crucial times. So thank you very much.
Thank you so much, Norma.
You're welcome. So we'll hear from our final speaker, Carolyn Tensikio. I know I'm not saying your name, Carlin, from the College of Nurses of Ontario. Carlin, I'll let you take over at this point in time, and you can correct me with your last name pronunciation. We're happy to have you here and speak about the changes in regulation with the medically assistants in dying.
Thanks so much, Norma. I really appreciate the time and the invitation. I just wanted to do a quick check with the WeRPN team to make sure that everybody can see my slides okay. Okay, great. Thank you so much. So hello, everyone, and welcome to CNO's presentation on medical assistance in dying, particularly as it relates to some of the recent legislative changes on MAID and Bill C7. So again, my name is Carlin Tensikio, and I'm a registered nurse and an advanced practice consultant with the College of Nurses of Ontario. And again, a big thank you to WeRPN for the invitation to speak with you all today, and happy Nursing Week. So today we'll provide an overview of the information we will cover in this presentation. First, I'll go over some CNO resources, provide you with a bit of history and background on MAID, describe some important changes from Bill C7, describe the various stages of MAID, describe some of the reporting requirements in the MAID process, and then take some time to answer your questions at the very end. So before we begin, I just wanted to signal that CNO has developed a number of resources to support your nursing practice, which includes a guidance document in nurses' roles and medical assistance in dying, an infographic which has a high-level table of these legislative requirements, a MAID webpage inclusive of many FAQs, and we also have curated a number of external resources, and this is found on the MAID webpage. And we will send a list of resources to the WeRPN team following today's presentation so that you all have a copy of it. So what is medical assistance in dying? As many of you are aware, and to recap, it's defined in the criminal code and can be provided in two ways. The first way is practitioner-assisted MAID, where a nurse practitioner or physician provides assistance by administering a medication to a patient at their request that causes their death, or patient self-administered MAID, where a nurse practitioner or physician provides a medication to a patient at their request so that they may self-administer the medication and in doing so cause their own death. So in June 2016, former Bill C-14 decriminalized medical assistance in dying for adults with decision-making capacity who are intolerably suffering and whose natural deaths are reasonably foreseeable, as seen in the Carter versus Canada case. In September 2019, the Superior Court of Quebec declares unconstitutional the eligibility criterion of reasonable foreseeability of natural death. The ruling, which applies only in Quebec, was not appealed, and the government determined to change the criminal code instead. The court suspends the declaration for invalidity for 6 months, and it ultimately was extended several times. In October of 2020, there was a reintroduction of Bill C7 in response to the Superior Court of Quebec Truchon decision. C7 was first introduced in February 2020, but progress on the bill's passage was delayed due to the pandemic, and a reintroduction was needed following prorogation of Parliament in August 2020. And finally, in March 2021, Bill C7 came into force, specifically on March 17th. So just wanted to highlight some of the more significant changes of Bill C7, and we're going to go into this in more detail throughout the presentation, but here are the main elements. So Bill C7 removed the 10-day reflection period. It also removed the eligibility requirement that the patient's natural death can be reasonably foreseeable. It also created 2 tracks based on whether natural death is reasonably foreseeable, and those tracks also have respective safeguards established. There's also an explicit exclusion of mental illness as a sole underlying condition to be eligible, and although this is time limited, there are also enhanced reporting requirements. So again, what changed? Bill C7 creates a 2-track approach to procedural safeguards for practitioners to follow based on whether a person's natural death is reasonably foreseeable, also known as RFND, highlighted in the green, or their natural death is not reasonably foreseeable, non-RFND, highlighted in the orange. There are now eased safeguards for RFND and new stricter safeguards for non-RFND. The legislation does not define what a reasonably foreseeable natural death is. It is connected to time, but flexible, and must be assessed on a case-by-case basis in relation to the specific person who is seeking MAID, and must consider the whole individual and their unique medical circumstances. There are also enhanced reporting requirements based on the 2 tracks, which we will explore later on in the presentation. So there are 4 stages in medical assistance in dying, and we're going to move through each stage as it relates to each track through the presentation. So the first stage is determining the patient's eligibility. Stage 2 is ensuring safeguards are met, and by safeguards we mean the measures taken to protect the patient and the practitioner. Stage 3 is obtaining consent and the various types of consent. Stage 4 is providing medical assistance in dying. And finally, there are reporting requirements that occur at any stage. Stage 1, determining eligibility. This is for all MAID applicants and applies to both tracks. The individual must be at least 18 years old, have the capacity to make decisions with respect to health, be eligible for health services in Canada, make a voluntary request that is not the result of external pressure, give informed consent to receive MAID, have a grievous and irremediable medical condition, which is defined as a serious and incurable illness, disease, or disability, and they're in advanced state of decline in capabilities, and the illness, disease, or disability state of decline causes them enduring physical or psychological suffering that is intolerable to the person and cannot be relieved under conditions that they consider acceptable. So it is subjective to that person. So what changed? It is largely the same eligibility as before, but Bill C-7 removed the requirement for the reasonably foreseeable natural death from the definition of grievous and irremediable medical condition. And again, there's an explicit exclusion of mental illness. So prior to Bill C-7, mental illness as a sole underlying condition was not explicitly excluded from MAID eligibility, though they were unlikely to meet the eligibility required. For example, natural death was not reasonably foreseeable. Bill C-7 clarifies that for the purposes of the grievous and irremediable medical condition, mental illness is not considered to be an illness, disease, or disability. The federal government has clarified that mental illness refers to the conditions that are primarily within the domain of psychiatry, such as depression and personality disorders. It does not include neurocognitive and certain neurodevelopmental disorders. This explicit exclusion sunset clause was for 2 years, and this will be revisited in the future. These individuals will not be eligible for MAID until at least March 17, 2023. This temporary exclusion will provide the government with more time to study how MAID on the basis of a mental illness can safely be provided. So there's more time to come up with protocols, guidance, and safeguards, and to make any recommendations. It is not clear yet what this will look like in the future, or if there will be a process and safeguards in place by March 2023. So we encourage you to keep your eyes on this issue going forward. So we're now moving on to stage 2, ensuring safeguards are met, and these safeguards apply to both tracks. The request for MAID must be made in writing and must be signed by one independent witness. So a person whose occupation is providing health or personal care services and who is paid to provide service to the MAID requester may be a witness, and this can be an RN or RPN involved in the patient's care, and this is truly the key legislative change that impacts RPN practice. There is also 2 independent doctors or nurse practitioners that must provide an assessment and confirm that all of the eligibility requirements are met. The person must also be informed that they can withdraw the request at any time and in any manner, and the person must be given an opportunity to withdraw consent and must expressly confirm their consent immediately before receiving MAID. And there is an exception to this, which is the waiver of final consent, which will be discussed later on in the presentation. So to summarize what's changed, it is now in 1 independent witness instead of 2 who must sign the written request. It can be a paid professional, personal, or healthcare worker who can now be an independent witness, which can be an RPN involved in the patient's care. And Bill C-7 again removes the 10-day reflection period for the RFND pathway. So we're still now on stage 2, ensuring safeguards are met, but these safeguards apply to non-RFND. So practitioners are accountable for ensuring that there are 90 clear days between the eligibility assessment and the provision of MAID, and this can be shortened if the person is about to lose capacity. So the assessment period begins and the clock starts on the day in which the first assessment takes place. And this could be triggered, for example, by the MAID assessor reviewing the person's file or meeting with the person engaging in consideration of that information, which forms part of that assessment. The date of the beginning of the assessment period should also be documented in some manner, such as in the patient's medical record, as it is expected that this date will be requested through the federal monitoring regulations. The practitioner must also inform the patient of the available services and offered consultations. The person and the practitioners must discuss the reasonable and available means to relieve the person's suffering and agree that the person has seriously considered those means. And the patient does not have to actually follow up or partake in those services or consultations. One practitioner must possess expertise in the condition causing the patient's intolerable suffering, though if neither practitioner assessing the patient has expertise, they must consult with somebody who does have that expertise and share the results of that consultation with the other practitioner. There is a bit of clarification from Health Canada regarding that expertise requirement. And the requirement is for that the expertise in the condition causing the unbearable suffering, not just in the condition that is a serious and curable illness. Specialization or certification is not required, and expertise could be obtained through special training or previous experience with the patients with a similar condition. So only MAID assessors are assessing the person's eligibility. So if a practitioner is being consulted for their expertise on the medical condition, they're not assessing the person's eligibility for MAID. So they may advise on the available types of services and or the treatment, the stage, state, or nature of the patient's condition, or on the status of the patient's state of decline. So again, to summarize what's changed, this is a completely new track. So these are all new safeguards, in addition to the safeguards that must be applied to all MAID requests. So moving on to stage 3, like with any procedure or activity, consent is always required as per the Healthcare Consent Act or the HCCA. Patients must be informed that they can withdraw their consent at any time. Immediately before administering MAID, the patient must be given an opportunity to withdraw their request and give express consent for administration. And Bill C7 permits the waiver of final consent requirement in specific circumstances. So this applies to both tracks, and it's really a backup in cases of failed self-administration of the medical assistance in dying medications, and we'll go into more details later. So with the RFND pathway, if they fear losing capacity to consent, they may create an advanced consent agreement. So what is an advanced consent agreement? An advanced consent agreement allows a patient who may lose capacity before their preferred date for MAID to waive the requirement for final consent if a number of conditions are met. And this applies to patients whose natural death is reasonably foreseeable. So practitioners must not implement the advanced consent for MAID in cases where the patient demonstrates by words, sounds, or gestures refusal or resistance to the administration of the substance to cause their death. And a demonstration of resistance would make the advanced consent arrangement invalid going forward. So if the patient regains capacity at a later date, they could consent to receiving MAID at that time, as long as they continue to meet all the eligibility criteria, or they could draft a new advanced consent arrangement with their practitioner. So Bill C7 clarifies that involuntary bodily actions, such as the individual twitching or physically recoiling from contact or the insertion of needles, for instance, do not equate to resistance or refusal. So there is an exception, and this is the exception to final consent, which applies to both tracks of MAID. So for cases of failed administration, this allows a patient to create a backup plan in case self-administration fails to produce death within a specified period of time, but they lose capacity in that process. So the patient can create a prior arrangement with a practitioner to be present at the time of self-administration, who will administer MAID if the patient loses capacity. And then the practitioner could then administer the MAID meds in accordance with the agreement. So we understand that in practice, based off of our consultations with some nurse practitioners, self-administration of MAID is actually pretty rare in Ontario for a variety of reasons, but it's still something to be aware of as the climate and the practice evolves. So finally, we're now at stage 4, providing MAID, which applies to both tracks. And it's important to note that practitioners can both be assessors or providers, and they don't have to be both, but many may act just as a MAID assessor. And as you're all well aware, and to recap some of the general accountabilities of nurses, specifically our nurse practitioner group, they use evidence to inform decision-making about the medications they use in MAID. They ensure the safe disposal of unused medications, communicate with patients and families about the process, collaborate with the healthcare team, and ensure final consent. And RNs and RPNs play a valuable role in this process as well. They may be inserting intravenous access for the administration of medications, educating patients and families about the process, and providing comfort and support to patients and their families throughout this difficult process as well. So reporting has always been required to Health Canada and the Office of the Chief Coroner, and this continues. So previously what was done was that when a written request had been made, this would be reported to these two bodies. So Bill C7 now requires reporting for when any assessment takes place following a request, and it's not just written, even preliminary assessments, and they must report regardless of the outcome to the patient. So whether they're not eligible or they change their mind or die of other causes. So Bill C7 also expands the data being collected, including information on race, Indigenous identity, disability, to identify any individual or systemic inequality and disadvantages in the MAID context. And while these federal requirements are in the criminal code right now, we did receive some recent information from Health Canada, and they've indicated that they are in the process of updating the regulations associated with MAID reporting. So there will be some new requirements to come into force with those regulations. And Health Canada has some information available online on how to proceed with the reporting in the meantime. So moving on to conscientious objection. So the law does not compel an individual to provide or assist in providing MAID. A nurse may have beliefs and values that differ from those of a patient and may not be comfortable providing or participating in MAID. So therefore, a nurse may conscientiously object. So conscientious objection should be based on considered reflection, moral concern, and informed choice, and not upon prejudice, fear, or convenience. Conscientious objection must not be directly conveyed to the patient, and no judgments about the beliefs, lifestyle, or identity or characteristics of the patient should be expressed. So if nurses can anticipate a conscientious objection to MAID, they have an obligation to notify their employers as soon as possible, or in the case of self-employed nurses, inform persons seeking MAID that they do not provide the service so alternative arrangements can be made. So nurses who conscientiously object to MAID are still required to provide any routine care that is not related to MAID. They must continue to provide safe, compassionate, competent, and ethical care until alternative care arrangements are in place to address the patient's plan of care. So providing or assisting in MAID can have a wide range of emotional impacts on healthcare providers, and we recognize that. Many providers express moral distress when grappling with MAID, and some experience intense negative emotions and internal conflict, while others experience positive emotions through helping patients at the end of their life. Debriefing after MAID is a critical component for supporting healthcare providers. It creates a safe space for the healthcare team to talk about the MAID process, and it's an opportunity to share perspectives and feelings about the patient, and an opportunity for team members to reflect on the experience and share how they are feeling. So we encourage nurses to participate in MAID debriefing sessions with their teams. And if you work independently or in an organization that does not have MAID debriefing sessions, we encourage you to find other supports, such as family, friends, colleagues, professional networks, or employee assistance programs. We recognize that being a part of the MAID process, again, is an intense emotional experience for nurses, and it's important to access these supports available to you. And as my colleague previously mentioned, it's truly important to reflect on your ability to take care of yourselves. And similar to that airplane metaphor, you got to put your oxygen mask on before you can put on the oxygen mask on for others. So it's important for nurses to decompress, especially after provision or going through this process, because again, there are many emotions and ethical considerations and implications of MAID to consider with the evolving legislation. So before I end the presentation, I just wanted to leave you all with a few key takeaways from this presentation. So the first one, truly the main legislative change for RPNs from Bill C7 is that they can be an independent witness, as they would be considered a person whose occupation is providing health or personal care services and who is paid to provide service to the MAID requester. And this can be an RPN involved in the patient's care. Number two is RPNs play a significant role in the MAID process. Some of their many roles include providing vascular access and providing comfort and support to patients and their families. And finally, MAID is a complex and challenging area of practice with many nuances and considerations, such as conscientious objection, for example. And if it does not align with your personal values, debriefing with your healthcare team is important. And again, the importance of self-care. So we understand that this legislation is constantly evolving. Again, we'll know more in the coming months, especially as the 90-day reflection period sort of takes off around July. So there is more to come. And as we keep abreast of these changes, we will ensure that our senior resources are up to date to support safe practice in this area. So this concludes my presentation on MAID, and I will now turn it over to the WeRPN team to facilitate the Q&A period. And if I don't get to your question today, please feel free to contact the practice quality team here at CNO at practicesupport@cnomail.org. Thank you again for the opportunity to speak and meet with all of you.
Thank you, Carlin, for keeping us updated with that very important legislative changes and for being here today to provide this important detail around MAID and medically assistance in dying. So now we're going to turn to the Q&A portion of our presentation. So if you're interested in asking a question, you can use the Q&A function on the Zoom, or you can feel free to write it in the chat. I will gather these questions and share them with the group, and we will hopefully get to everybody's questions. So I've got a question here from Jackie. How do you get the fundamentals of palliative care certificate? I care for palliative care in home care. So this is a community nurse. Jackie's looking for education. I'm not sure which one of our panelists would like to answer that.
I can take that one, Norma.
Great, thanks.
So the fundamentals is offered primarily through the pain and symptom management consultants across Ontario. So it depends on what geography you're in on how to access those. It's really as easy as putting in fundamentals of palliative care and your geography in the internet, and it should pop up where that access is. But if you can't, people can actually email me and I can redirect you to whoever that is.
Fantastic, thank you. We've got another question that, Leslie, it may be appropriate for you. I'm interested in learning more about Indigenous competencies. Is there a resource link for that wonderful comprehensive work? Thank you, Leslie. So that came from Kim.
Yeah, and again, you know, I'm a white settler and will make missteps and I'm on my own path of learning. Certainly there's the Sanya Indigenous Cultural Safety Certificate. I've completed that. Coursera has a Indigenous certificate too, which is a free certificate through the University of Alberta. That's an excellent one. Hospice, Virtual Hospice of Canada has liveinmyculture.ca, and there's a number of different Indigenous communities that have little excerpts, and you know that's the other piece too, that we have got many Indigenous communities and peoples, so it's not one size fits all, and that's really important. Cancer Care Ontario, which is now part of Ontario Health, has some online learning and some competencies. So there's lots of different paths available, and I think it comes into the next question too, which was speaking to the importance of ceremonies for FNIM communities at the end stage of life, and how nurses can help patients and families access these ceremonies, given that we work in colonized institutions. So, you know, this is really true. This is one of the barriers. I mean, we've seen systemic racism, not just in the news, but I think we see it day to day in some of our work settings too. And the approach to palliative care is, you know, what is important to you? How can I help you live your life and your death the way you want it to be? And really asking people about their values, goals of care and wishes. And then as nurses, it's our job to advocate to remove those barriers. So if somebody is in an institution and ceremony is important, know what your chain of command is, for want of a better phrase, or, you know, what's your process for trying to remove those barriers to enable that person to receive the approach to care that they absolutely want. So it's really complex. It's very challenging. It takes a lot of courage. It takes a lot of humility on your own part to sort of accept when you're wrong and recognize when you're not necessarily doing things the right way. But it's just really about, you know, making the space as safe as it can be. And then, as you know, was pointed out to the panelists in the chat, only the person can decide if something is culturally safe, but it is our job to know what can we do to advocate for that and try and create that space. But it's I think, you know, when there's the right intent and political will, and there's a coming together that people want to do this, they can really make a difference.
Yeah, thank you very much, Leslie, for that and responding to the cultural aspects of palliative care and addressing some of the additional questions that are here in the chat. I have a question here for Carlin. Can RPNs witness for family members?
Thanks, Dharma. That's a great question. So again, we'd have to go back to the definition of what's outlined about who can be a witness in the criminal code. And again, there are a number of different requirements that must be met. So that person has to have an occupation providing health or personal care services who is paid to provide that service to the MAID requester. So in most cases, RPNs are not being paid to take care of their family members. So my assumption is that they would not fit that definition. And going back to CNO's practice standards of, you know, that conflict of interest piece, where nurses, you know, must assess whether they have a conflict of interest in the provision of someone's healthcare. And in that case, you know, most likely that RPN would have a vested interest as that person's loved one. So in this case, they would not be from the definition of the criminal code, they would not be suitable for an independent witness in the MAID process.
Thank you for that. Melanie writes here, she's an RPN student in her final semester. Congratulations, Melanie. We're happy that you're part of our audience today. And she's highly interested in palliative care. She'd like to know what steps to take postgraduate to prepare herself to specialize in and to become fully involved in this level of care.
I'm happy to tackle that one again.
Sure.
Congratulations, Melanie. That's really exciting. So it's a number of different things. I mean, it's education as well as experience that will really enable you to become that sort of level 2 specialized nurse. So the primary thing is to go to the Ontario Palliative Care Network, download the competencies, print them off, see what the requirements are to meet that generalist and specialist level, and aim to work in an area where you're going to be applying a palliative approach to care in every single sort of situation in your work. So that could be hospice, that could be on a palliative care unit, you know, that kind of thing. And then access to those particular certifications, check out your local college to see if they do a certificate there. The fundamentals, APSI, all of those pieces can put you on the pathway. So it's really about looking at the competencies, finding that right work setting, and then working your way through the educational processes to apply those, to get the knowledge to apply in practice, and then develop your skill set.
Excellent. And I think I noticed in the chat there that Tara put in a link to the Ontario Palliative Care Network as a resource. So thank you for that, Tara. Another question here. Who diagnoses a patient as palliative, a doctor or a nurse? And what signs indicate that a patient is palliative or is a palliative candidate? I'm not sure who would like to take that one.
I can start with that one again. So nobody's really diagnosed as palliative. And again, this is one of the myths that we're trying to move away from, that it's not a label type. So we wouldn't refer to a patient as palliative, or we wouldn't diagnose them as that. There is an early ID toolkit, early identification toolkit, to recognize who would benefit from a palliative approach to care. And there's a number of different tools. What we use in the area I work in the region, we use the gold standards framework from the UK, which is, does somebody have a life-limiting progressive illness? Are they likely to die in the next 12 to 18 months? And are we starting to see signs of decline? And those questions, those reflective questions, really enable you to select people that would benefit from a palliative approach to care. But there are other early identification tools as well, and it really helps enable us to recognize people earlier in their disease trajectories and not wait until just end of life when people are sometimes in crisis. And those two are available through that link in the resource section. So it's the early identification toolkit.
Excellent. Thank you, Leslie. Another question here is, and maybe this toolkit is part of the resources, but do you have resources you can recommend for referral purposes for family members on the grieving process following the loss of a loved one? It's a really good question.
I think I'd sort of defer to what Jackie said too. You know, it depends really where you are, and the easiest way is to reach out to the care team that was involved or your primary care team and make that first step for asking for help, and they can assist with some navigation to the different resources, because it really varies depending on what region you're in, where you live, all of those things. So my first response would be reach out to the care team that was involved and reach out to your primary care team too.
Great. And another question, this may be for you, Carlin. How has MAID changed the palliative care landscape in the past few years? And has there been more patients asking for MAID after being deemed palliative?
I think that's a fantastic question. If you would like some recent statistics on, how many patients have accessed MAID since 2016 when the legislation came into effect, I would encourage you to take a look at the Office of the Chief Coroner, who has some amazing statistics on this. My experience is from critical care and ICU, so I personally don't have any experience in terms of, what the MAID landscape has done. But we do have an excellent recording on cno.org where we had Diane Gwartz, a nurse practitioner who is a MAID provider, talk about some of this experience. And I'm happy to share the link with the WeRPN team so that you can really get a sense of her practice experience as a MAID provider and her perspectives on how MAID has changed the palliative landscape. But I've had some anecdotal conversations with some clinicians, so nurse practitioners and physicians through the ministry, and they're finding it quite difficult to have access to MAID, especially in rural areas of Ontario, where there may not be so many MAID providers in those areas. So I think access is kind of an issue in certain areas of the province. So that's definitely changed things. And, given that the legislation for Bill C7 with the new track came into effect on May 17th, we're hoping to have a really focused monitoring on how this will roll out, especially when the 90 clear days are coming into effect. So between now and July, and seeing what will happen after July to see how does Bill C7 truly work out and is implemented in real time in practice. So more to come. And I think another great resource to sort of get a sense of what the MAID landscape will look like is to look at Health Canada and the ministry's reporting on how many people have access MAID in the last little bit.
And Norma, I can probably add to that too. So MAID and palliative care are two very separate things. They do intersect, and I definitely encourage you to go to the resources that Carlin's highlighted. But usually what we find is when people have access to high quality palliative care, that even if they've requested MAID, they don't necessarily proceed with MAID. So in the same way that, there's been strong advocacy for access to MAID, we still need to continue that advocacy for access to high quality palliative care, which can really help people avoid crisis, avoid hospital deaths, have less complex grief and bereavement issues. So, the two intersect at some point, but, MAID it is a insured service through Health Canada, and again, access for that is challenging, but equally access for palliative approach to care. So everybody in the chat who's interested in coming into this field, we really welcome you, because we need more and more skilled providers and increased access. So that's great to see.
Yeah, just fantastic resources that are out there, and we're, you know, and the high need for nurses in this area as well. And there's some questions about education and where they can get the education, and certainly when you're looking to specialize, you can contact us at WeRPN, and we can ensure that there's some resources made available for additional education in palliative care. There's questions about getting a hard copy of the competencies as well. Leslie, would you know if a hard copy is available to the audience?
We're just encouraging people to print and download, and Tara might be able to answer that in the chat, but that's what we do at the moment.
Perfect. Thank you very much. And just for the rest of the audience, to let you know that this webinar is being recorded and it can be reaccessed at any time. So it will be made available. There were some questions about that as well. So certainly you can revisit the webinar and the discussion today that we've had on this very important topic. So I want to thank our speakers today. They've done an excellent job. We've had many questions and great questions from the audience as well. And we want to thank our audience for joining us and taking the time this morning for day 3 of Nursing Week. We really appreciate the support from our speakers to continue to build the wealth of knowledge that our PNs have and to add to this area of practice. So thank you everyone for joining us this session. It is my pleasure to have hosted the event and start off our morning together. If you all have some time, just bear, we have another session that's starting at 11 a.m. this morning, and it will cover wound care and the role of skin barrier and inflammatory skin conditions. We'll hear from nurses with wound care expertise, discuss best practices in wound care management, and the second part of the event will cover the basics of skin barrier and the concept of ceramines and pH and how they play a role in common inflammatory skin conditions like atopic dermatitis and acne. If you can't attend again, don't worry. All the events for Nursing Week will be recorded and will be shared on our website. I also want to point out that tomorrow evening at 7 p.m. we have a very excellent motivational talk that's happening with Michael Chikawanin, who uses his personal experience to speak about how he has overcome pain and struggle, and to inspire a new perspective of life, sense of hope, and a desire for change. So visit WeRPN.com to learn more about this very exciting event and motivational conversation for tomorrow evening. In closing, I want to wish all of my colleagues and happy Nursing Week, and thank all of my colleagues who have spoke today on this great topic of palliative care. And I hope everybody has a great rest of their day. Take good care.